Good morning, everyone. Today's topic is muscular dystrophy. First, we go through what is muscular dystrophy, then the incidence, types of muscular dystrophies, and pathophysiology. Next, finally, genetic basis of DMD and clinical manifestations, the Gaucher sign, pseudohypertrophy of muscles, and the investigations, and goes through the medical management. First, the introduction of muscular dystrophy. Muscular dystrophy was first described by Dr. Charles Bell in 1830. These are the group of disorders characterized by progressive degeneration of groups of muscles. Muscular dystrophies are characterized by progressive skeletal muscle weakness, defects in muscle proteins, and the death of muscle cells and tissue. This is an image of muscular dystrophy. Here is the normal muscle, here is the atrophied muscle. This atrophied muscle is the muscular dystrophy image. Next, the incidence of muscular dystrophy. Muscular dystrophy is a group of rare hereditary muscle disease with prevalence of muscular dystrophy is 29 per 1 lakh population. An observation in eastern India reports a high incidence of DMD cases in Muslims compared to Hindu population. A report submitted in 1997 estimated that there were 22,000 DMD cases present in India and more than 2,500 cases added every year. Next, about the types of muscular dystrophies. First one is the Becker muscular dystrophy, congenital muscular dystrophy, Duchenne muscular dystrophy, distal muscular dystrophy, Emery-Dreifuss muscular dystrophy, facioscapulohumeral muscular dystrophy, limb-girdle muscular dystrophy, myotonic muscular dystrophy, oculopharyngeal muscular dystrophy. Although many types of muscular dystrophy are found, but there are only a few which are frequently seen in physiotherapy practice. The most common muscular dystrophy is the Duchenne muscular dystrophy. Duchenne muscular dystrophy is caused by the mutation of the gene that is responsible in production of a muscle protein called dystrophin. Dystrophin is required for muscle cells to keep their shape and work properly. An abnormal gene cannot produce this protein and thus the muscle cells collapse and die. Next, what is dystrophin? I am going to explain what is dystrophin. It is a protein found in the muscle fiber membrane. Its helical nature allows it to act like a spring or shock absorber. Dystrophin links actin in the cytoskeleton and glycans of the muscle cell plasma membrane known as the sarcolemma. In addition, dystrophin also regulates calcium levels. Next, the pathophysiology of muscular dystrophy. The exact mechanism of pathogenesis is not clear in Duchenne muscular dystrophy. There are some theories which explains the probable pathophysiology of Duchenne muscular dystrophy. First, the neurogenic theory. According to this theory, the primary problem is in the nerve supply to the muscles rather than the muscles itself. And this have been suggested by some as the explanation for the high association of intellectual impairment in Duchenne muscular dystrophy boys. Next, the vascular theory. According to this theory, the problem in the muscles was secondary to an impairment in their blood supply. Next is the membrane theory, most current accepted theory. According to this theory, the cell membranes are genetically altered, causing a compromise in cell integrity. An increase in the activity of muscle proteolytic enzymes may accompany the membrane alteration, leaving the muscle cell vulnerable to degeneration. Next, about the genetic basis of Duchenne muscular dystrophy. Duchenne muscular dystrophy is inherited. The abnormal gene for Duchenne muscular dystrophy is found in X chromosome, hence it is X-linked disease and is usually passed down from mother. Boys have one X chromosome inherited from their mother and one Y chromosome inherited from their father. If a boy inherits an X chromosome with the abnormal gene for Duchenne muscular dystrophy from his mother, he will develop this disorder. Girls have two X chromosomes chromosome. If a girl inherits an X chromosome with the abnormal gene for Duchenne muscular dystrophy, the other X chromosome has a normal copy of the gene. The normal gene can usually make enough protein to prevent symptoms. Girls are not usually affected by Duchenne muscular dystrophy. They are carriers. A woman carrying the Duchenne muscular dystrophy mutation can develop mild muscle weakness and an enlarged heart later in life. If a woman carries the abnormal gene for Duchenne muscular dystrophy, each of her children will have 50% chance of inheriting the X chromosome with the abnormal gene. Thus, if your son inherits the abnormal gene, he will develop Duchenne muscular dystrophy. If your daughter inherits the abnormal gene, she will become carrier. Next, the clinical manifestation of Duchenne muscular dystrophy. Onset, there will be no abnormalities in early infancy in 50% of boys with Duchenne muscular dystrophy. The disease usually noticed at about 3 years of age. While in the early months of walking, he walks more slowly, falls more frequently, does not run normally, and climbs stairs only with difficulty. Progression. With time, certainly at the age of 4 years, there will be slightly lordotic stance and a whirling gait combined with the perceived locomotor difficulties so to increase diagnostic suspicions that there may be a significant muscle weakness. A boy will be unable to jump up even a very small step. Climbing stairs will be slow and laborious. Next, about the Gowers sign. It is an important sign seen in the muscular dystrophy. If the patient tries to getting up from the floor, this will always start with the person going to prone and depending on age using his hands to some extent to assist in standing up. By the age of 4, typical Gowers maneuvers are typically seen. A Gowers sign consists of a typical getting up manner by the child using support of various parts in the lower limb and appears as though he is climbing up into standing using support of his lower limbs. Here is an image of Gowers sign. A child with Duchenne muscular dystrophy may use this movement pattern when getting up off the floor. First, start on the hands and knees facing the ground. Next, lift the bottom and plant the feet in a wide stance. Next, walk the hands toward the body. Next, walk the hands up the legs. Use the hands to push off the thighs to reach an upright position. Next, the muscle weakness. There will be typically element type of motor weakness. There will be progressive muscle weakness of plantar flexus, aortus, quadriceps, gluteal muscles, long extensors of hand, biceps, triceps, deltoid, pectoral muscles, latissimus dorsi, and some other shoulder girdle muscles. Pseudo hypertrophy of muscle. In contrast with the wasting of muscles as in other element type muscle weakness, the child with DMD, that is Duchenne muscular dystrophy, develops hypertrophy of the muscle. But this hypertrophy is not exactly increase in the muscle bulk, but is due to abnormal deposition of fatty tissue and fibrous tissue in the muscle. Hence, it is termed pseudo hypertrophy. The calf muscles, quadriceps, biceps, and extensors of wrist and fingers show pseudo hypertrophy commonly. In coordination, there will be loss of muscle coordination. Child may seem unsteady, clumsy, frequently falling or waddle when they walk. Next, the toe walking, the muscles become tight around joints, limiting movement. When walking becomes difficult, children may walk on their tippy toes or balls of their feet. The superficial reflexes are lost. Later, the deep tendon jugs are also lost, although angle jug tend to be preserved. With the progression of the disease, there tends to be better power retained in the distal muscles than in the proximal, in hamstrings than quadriceps, in deltoids than biceps or triceps, in wrist flexors than extensors, in neck extensors than flexors, and in plantar flexors of the feet than dorsiflexors. The joint contractures develop at the hips, knees, elbows and wrist, and in majority the lumbar lordosis is replaced by a kyphoscoliosis due to muscular imbalance. Diaphragm is the only muscle that is not involved in the Duchenne muscular dystrophy, but because of inactivity, development of kyphoscoliosis, decreased thoracic mobility, and respiratory complications set in. By the early teens, muscle weakness is extreme and extensive. Dependency will develop for functional activities like dressing, bathing, toileting, and turning in bed in night. Some children have learning disabilities, and the IQ is 75 to 80 percentage and does not deteriorate with age. In very few types of muscular dystrophy, there will be mental retardation. There will be GIT abnormalities like constipation, vomiting, etc. Next, about the investigations of muscular dystrophy, muscle biopsy, serum CPK levels, EMG, urine or serum myoglobin levels, and serum creatinine. First, about the investigation procedure of muscle biopsy. The muscle biopsy will show extensive variation in the size of the fibers with increased infiltration of fatty tissues and fibrous tissues. Serum CPK levels. CPK is an enzyme found in muscles. Its levels are elevated. EMG. It shows typical myogenic pictures with a small amplitude, small duration, polyphasic potential. In later stages of disease, there may be presence of fasciculation potentials. Next, urine or serum myoglobin levels. When muscle is damaged, the myoglobin is released into the bloodstream. In Duchenne muscular dystrophy, myoglobin levels are raised in serum and urine. Next, the serum creatinine. The serum creatinine levels are raised in muscular dystrophy. Then about the medical management of muscular dystrophy, steroid medications, antihypertensives, genetic counseling, orthopedic management. These are the medical management. Steroid medications can slow the progress of this disorder. Prednisolone can help to keep muscles strong and working. Deflazacort works in the same way as prednisolone. Certain times DMD child develops cardiomyopathy with high blood pressure. Antihypertensives may be advised by the physicians. Genetic counseling. If any of the family member has Duchenne muscular dystrophy, genetic counseling might be helpful. Orthopedic management. Certain times a few corrective surgeries may be necessary to make the child functionally independent. These are about the muscular dystrophy, and thank you.